Good evening, everyone. Good afternoon, rather, everyone. I'd like to welcome you to an interactive panel discussion on the management of urticaria. We have to know how to do treatment and diagnosis in our clinical practice. So we're very fortunate to have two world-renowned speakers who will help guide us in this discussion. And this will be a very intimate and unique fora in that we will be also asking the audience to ask their questions during the discussion points so that we can be more interactive and that we can get the best of this session. So I'd like to introduce first the panel. I am Professor Mauricia Recto, an allergist from the University of the Philippines, Philippine General Hospital, and I'm honored to introduce our world-renowned speakers, the first of which is Dr. Kanokvalay Kultanan, a professor of dermatology at the Department of Dermatology, Faculty of Medicine, Siri Raj Hospital, Mahidol University, Bangkok, Thailand. She is the president of the Dermatologic Society of Thailand and a scientific committee member of the Allergy, Asthma, and Immunologic Society of Thailand. I would also now want to introduce a speaker who we are very well familiar with on urticaria. He's really one of the gurus of urticaria. And this is Professor Markus Maurer from the Charité Universität Medizin Berlin, Department of Dermatology and Allergy in Berlin, Germany. He is a professor of dermatology and allergy and the head of the dermatology allergology at the Department of Dermatology and Allergy at the same institution. He is also one of the co-authors in the APAACI guideline that we use usually for diagnosing and managing urticaria. So I'd like to welcome Professor Markus and Professor Kanokvalay. These are their disclosures. And these are my disclosures as well. And this is the disclaimer from the company. And I'd like to reiterate that if you have any questions at any time during the point of discussion, please feel free to send your questions through the chat box so that we can incorporate it in the discussion. They may be questions, they may be comments, but it would be more exciting if we participate. So let me start the ball rolling by putting everything in context. And this is about the disease called urticaria. It is a mast cell-driven disease that is basically a cutaneous symptom complex rather than a disease entity. And you're all familiar with the clinical presentation. We don't have to discuss it in depth, how the wheals look like, how often it comes with angioedema. But this disease is something that is quite common in our practice. And we see lifetime prevalence rates to be as high as 23%. The acute form of urticaria has a higher prevalence, more or less of 1 to 14.5%. And chronic urticaria has an incidence of around 0.1 to 3%. Now, chronic urticaria, chronic spontaneous urticaria is the more problematic type of urticaria. And it seems that based on studies, in Asia, we have a higher point prevalence compared to Europe and North America. And that the point prevalence estimates for CSU in children is higher than adults and more common in adult women than men. But there were no specific differences in children less than 15 years. So urticaria is a disease that will not kill you, but can make life quite miserable and can make costs quite high because of its chronicity. And you see that the indirect cost of treatment and direct cost of treatment cause a big socioeconomic burden because many of patients are insufficiently treated and may be not be able to perform their work or their daily activities well enough. So urticaria is not just an allergic disease. It is actually occurring because of either immunologic factors or non-immunologic factors that all lead to mast cell degranulation. And you would have the release of histamine that would lead now to the wheals, the hives, the itching, and the angioedema that our patients experience. So urticaria is subdivided into two subclassifications, acute and chronic, based on the length of or the duration of disease. And I have summarized here some known triggers for urticaria, whether acute or chronic. And we see for acute urticaria, a lot of the times it's idiopathic, as well as patients with chronic urticaria may also have some idiopathic causes. So finally, for this brief overview, that chronic urticaria can be further subdivided into chronic spontaneous urticaria and chronic inducible urticaria based on the guidelines that we use even in this part of the world, which are the APAACI guidelines. So this is not really the focus of this discussion. We will be discussing some practical points in the diagnosis and treatment of urticaria. So let's go to the first discussion point. And this would be on some diagnostic dilemmas in urticaria. Now, because we know that there is that guideline, and in the guideline, the APAACI guideline, we have seen that there are recommended diagnostic tests for chronic spontaneous urticaria versus acute spontaneous urticaria that does not have or doesn't need any specific diagnostic procedure, and that for chronic inducible urticaria, we also have some recommended tests. But I would now like to ask our experts, Professor Maurer and Professor Kultanan, what would be your experience when you face these dilemmas, and how would you help solve these diagnostic dilemmas in urticaria? May I call on Professor Kultanan first?
Actually, for example, I would like to add my Asian perspective point. Many urticaria patients will request for skin tests because they believe that their hives are caused by allergic reaction to foods or other external causative agent. I think this is the real problem. Actually, for the role of skin testing in acute urticaria, you know that acute urticaria usually does not require a routine diagnostic test, as it is usually self-limited. However, the only exception is that when you suspicion of acute urticaria due to type 1 reaction, such as food allergy in sensitized patients. In this case, skin tests may have some role to avoid re-exposure to relevant causative factors. So that's my point. For chronic urticaria, skin tests include autologous serum skin tests to detect serum histamine releasing factors and autoantibodies to Fc epsilon R1 or to anti-IgE on mast cell surface, and provocation tests and threshold tests for chronic inducible urticaria if it is concomitant with chronic spontaneous urticaria, and in only some selected cases with frequent acute exacerbation, and you suspect that external agent may be responsible for the flare-up. So in this case, skin prick test may have some role, but not the entire role. Marcus, what do you think?
I absolutely agree with you, Kanakula. This is the biggest problem, not only in Asia, but also here in Europe. Most patients who have chronic spontaneous urticaria think that this is an allergy, that it has something to do with the food they eat, the air they breathe, the creams they use, the shower gel they use. And we know that this is not the case. And that diagnosis aimed at allergy is not going to help these patients. No, it is a dilemma because sometimes it takes longer to try to convince patients that the test is worthless than to actually do the test. But we should work as specialists and experts to discourage the view that this is an allergy. It is not. It is an autoimmune disease that comes from autoantibodies, that comes from within. It's an internal disease that manifests at the skin, and we should talk about this so that patients know that we understand the causes and don't need more tests to help them. We can help them. But I want to add one thing, Marisha, if I may. The dilemma starts much earlier. I mean, we, Kanakula, you, everyone has the problem of this. I need to have the right test, doctor. I need to find the underlying cause. But the step before that is actually very important as well. We know from recent studies, and I was really surprised by these results, that it takes a long time for patients to get the diagnosis and to get the correct diagnosis. So obviously, many patients have months and years before someone tells them what they have. And the chance is high that they're getting told something that's not right. And I would like to discuss with you and maybe also get our viewers' input on how to address that, because I cannot understand how a disease that is actually quite easy to diagnose. No, you see the wheals, you see the angioedema. Very few diseases come with these signs and symptoms. And what can you confuse it with? No, so I think part of the reason is that we and GPs and family doctors often do not see the wheals when the patient is in the practice, often do not see the angioedema. No? And one of our recommendations, and I always do that, is to let patients show us their pictures. No? They all take pictures on their phone, and then they're actually happy to show us what this looked like when they had wheals, when they had angioedema.
So I just noticed, Professor Maurer, that the new APAACI guidelines for chronic spontaneous urticaria has recommended now IgE and IgG anti-TPO. This is something that's new from the last update. So why was this added? Because IgE is really a non-specific test for allergy, but I'd like to ask, maybe you would know the rationale for adding this to antibody tests?
Very good question, Marisha. Certainly not because we're interested in allergic IgE, no? But IgE is a good marker for underlying cause, in the sense that if you have normal or elevated IgE, then that points to autoallergic chronic spontaneous urticaria. But more important, if you have low IgE in, I don't know, let's say 8 or up to 40, no, then this is a good marker for autoimmune chronic spontaneous urticaria. And why is that important? Because we know that these patients, up to 1/3 with autoimmune chronic spontaneous urticaria, are harder to treat with antihistamines and omalizumab, have a longer course of disease, have other comorbid autoimmune diseases, including Hashimoto, more often have angioedema, more often are female. So there's a bunch of clinical features that are important for us as physicians to know about, that we can base on measuring IgE. If it's low, I always think, this could be a patient where I really need to give it all we have. And this is even stronger when this patient also has IgG anti-TPO. So low IgE and high IgG anti-TPO will make that mix that makes me think of autoimmunity, both autoimmune urticaria, but also to check the patient really for Hashimoto, vitiligo, rheumatoid arthritis, other comorbid autoimmune diseases.
Okay, that is really very interesting. You know, we always think of IgE as a molecule for allergy, but now we use it as a gauge for the presence of autoimmunity. And Professor Kultanan, for the use of the autologous serum skin test, do you use that also to diagnose autoimmunity in your center?
Previously, we used to perform autologous serum skin test. So when the test is positive, so we diagnose the patient as autoimmune urticaria. But now it's rather non-specific screening test for histamine releasing factor, not only autoantibodies. I mean, IgG anti-Fc epsilon R1 or IgG anti-IgE. Not only that, autoantibodies, but histamine releasing factor of any type. So it's not so specific like previously we think.
Okay.
What do you think?
Yes, we have not been using it also too much. But there's something very interesting, Professor Maurer. In Europe compared to Asia, it seems that the issue of pseudo-allergy is an important discussion point, no, about the triggers for urticaria. And well, in our part of the world, like in the Philippines, we hardly consider pseudo-allergy. I know your thoughts about why in Europe it is a major concern as a cause of urticaria.
It is a major concern because many patients tell us that food makes their urticaria worse, or that they think that they have this because of what they eat. And we know that this is not food allergy, because food allergy manifests very differently, and you should stop having urticaria when you stop eating the foods that you're allergic to, and you do. So many years ago, an explanation was sought for how can food explain worsening of urticaria when it's not allergens in the food. And we found certain types of foods that through other mechanisms can increase the disease activity in chronic spontaneous urticaria. Now, this has lost a lot of its oomph because of many reasons. We now understand the causes much better. So we think of autoallergy more of a trigger where eating certain foods or being stressed or having an infection can make the disease worse in our patients, but it's not the underlying cause. I think the whole thing got a lot of drive because of the discovery of the MUS-related gene protein coupled receptor X2. Oof, what a mouthful. This beautiful receptor is very promiscuous in that it detects things that come from the outside and from the inside of the body and translates them to higher excitability or activation of skin mast cells. So I think we haven't heard the end of it, but we today do not explore pseudoallergy in all of our patients. It is something which we do in select patients, especially patients who do not respond to standard therapy, antihistamines, omalizumab. This is where we take a step back and we try to figure out, are there triggers such as pseudoallergy that we can work on?
Okay, thank you very much. And so basically for this portion, we have summarized it here that for acute urticaria, no testing is needed. For CSU, limited testing. And that maybe allergy skin testing may be of little value in chronic, but some value in IgE-mediated acute urticaria. Okay, so now let's go to the next discussion point. What would be some reasons for the misdiagnosis or delay in diagnosis of urticaria? So, Professor Maurer, what would be your thoughts?
I wish I knew. I think you guys in Asia know better because you have higher prevalence rates, which I think are probably explained by a better diagnostic approach, because I do not see a reason why there should be geographic differences in the prevalence of chronic spontaneous urticaria. Okay, fine. I'll offer two explanations, maybes. One is that what we talked about before, patients do not have their signs and symptoms. Look, we're in dermatological practice, for example, if someone shows you their psoriasis, you know this is psoriasis, or their atopic dermatitis, you know, but many patients with urticaria do not have their wheals when they are in the doctor's office. So I think that is a problem. The other reason I think that contributes to the delay in diagnosis and the high rate of misdiagnosis is that this disease is first diagnosed not by a specialist in most patients. It's diagnosed by a family practitioner, a GP, maybe a pediatrician, and the knowledge on skin diseases in general, but on chronic urticaria in particular, is not really good in many parts of the world. We need to educate as specialists other physician communities, our friends and colleagues in general practice, so that they become more confident in diagnosing urticaria and not calling everything a rash or, everything is atopic dermatitis. Sometimes I get that feeling that GPs think, oh, there's something that's itchy in the skin, must be atopic dermatitis. And in many cases, it is not. So I think we can work on this delay in diagnosis by better education and by asking patients to show us their pictures when they're in our office.
Okay, Professor Kultanan, what do you think would be the reasons in Asia for this over-diagnosis?
I think common reason observed for delayed diagnosis in Asia. First, some patients diagnose themselves as eczema and use topical medication. And some patients, even with chronic urticaria, will first seek for advice from non-medical personnel first and try to find out the responsible causative agent they believe, such as try to eliminate various kinds of food by themselves. And then some patients try to treat themselves first by using over-the-counter drugs. Moreover, some took first generation antihistamine from the drug company, which might cause drowsiness and adverse effect. So, and this is also the reason for non-adherence. So when some took medication irregularly or as needed, and then they fail to control their symptoms by themselves, at that time, they will seek for specialists or doctors. And for misdiagnosis, I think some patients with multiple problems, for example, patients with atopic dermatitis who develop urticaria. And sometimes doctors may think that their issues are caused by atopic dermatitis and do not pay so much attention because the patient they think that the patient should have no two disease, something like that. And even some patients with CISU and symptomatic dermographism, this may be cause some misdiagnosis. And another group of patients is those with disease related to urticaria and syndrome which present with hives or angioedema, for example, urticaria vasculitis or UP or something like that, urticaria pigmentosa. So that's my point of view.
Okay, thank you, Professor. Now, we have a question from our audience, and we really would like to encourage people to ask during these discussion points. Okay, so the first is, I think it has something to do with the triggers of urticaria. And the question is, which implications have been connected to chronic inducible urticaria? So, Professor Maurer?
Yeah, very good question. Thank you very much. We don't talk enough about chronic inducible urticaria, maybe because it is not so common as chronic spontaneous urticaria, but believe you me, many patients with SINDU, as we call it lovingly, have a really hard life and a really bad disease. They can't go out because it's too cold for cold urticaria patients, or because it's too sunny for the solar urticaria patients. And the issue is that it is really difficult to avoid most of the triggers that cause chronic inducible urticaria. Now, how can you stay out of the sun? How can you not be cold? In my country, it's cold half of the year. You would have to move to avoid your trigger. And the issue is also that many patients with chronic spontaneous urticaria also have chronic inducible urticaria, that they have 2 or 3 urticarias. And if we don't figure out which urticaria exactly they have and how many, then it becomes very difficult for patients to find a concept on how to deal with this disease. No? We don't want patients to, arrange their entire life around their disease. We don't want them to avoid these triggers in the sense that they should live normal lives. They should be able to do everything that we can do. And this is why it becomes important to understand these triggers and to bring them on board in our treatment concepts. No, it's not enough for patients to receive advice that, just try not to get cold. No, that doesn't help. That doesn't work for patients. We need to give them something to work with so that they can protect themselves from the induction of wheals by their relevant trigger.
Okay, Professor Kultanan, what would you have to say about infections and urticaria?
Infection is common as a causative factor for acute urticaria, especially URI in children. However, in chronic urticaria, infection has a minor role, but we think that some patients who have the history of dyspepsia, you can investigate for H. pylori infection. So this is a controversy topics. However, we cannot exclude H. pylori as a cause or exacerbating factor of chronic spontaneous urticaria.
Okay. So, Professor Maurer, would you like to share this very briefly? These tips, this actually came from the latest APAACI Gallen guidelines for urticaria.
Yeah, sure, Marisha. And I would like to invite everyone to join the next session where I will go in a bit more detail on the update of this wonderful global guideline, which now is, as you can see in the title, also an APAACI guideline. So more Asian input and more Asian relevance in this guideline. Look, this table is very straightforward. The 7 C's of the diagnostic workup confirm, look at the cause, cofactors, comorbidities, consequences, components, and the course. And what this reflects is really a broader view at what we should do when we see patients in our daily practice. No, let's step away from this question, where does it come from? We know where it comes from, and let's be broader to help patients get a concept for their disease. Make sure that it is urticaria. Okay, that's easy. We know how to do this. Look for markers of type 1, type 2B autoimmunity. Talk about triggers, talk about comorbidities, the impact and consequences of the disease. And the last one, look at the course. This is so important. You know, we can only treat patients to the best that we can when we know where they stand before we start the treatment and when we use tools to monitor their treatment. No, use the UCT, the Urticaria Control Test, or for the first time in the guideline, the angioedema control test for those patients who have angioedema. So really worth to take a look at this approach. It is novel. It is nice because it looks at urticaria in a broader sense, and it provides better advice for better diagnosis and workup in patients with CSU.
Okay, so thank you very much for sharing this. And now we will move on to the next discussion point. And I'd like to ask Professor Kultanan, you know, we're now right in smack the COVID pandemic, and a lot of our patients are complaining or suffering from urticaria. I don't know if you've noticed that also in Germany. So would you see a relationship between the emergence or the increased prevalence of urticaria now amidst the COVID pandemic?
Yes. Acute urticaria can be one of skin manifestations of COVID-19 infection. It can occur before, during the course, or after COVID-19 infection. And most skin lesions resolve within days or up to 2 weeks following treatment with antihistamine and oral corticosteroid. That is acute urticaria. However, for our chronic spontaneous urticaria or chronic urticaria in the times of COVID-19, there is no evidence that patients with chronic urticaria have a higher risk to get COVID-19 infection due to the disease. However, treatment with H1 antihistamine and biologics such as omalizumab does not represent an additional risk factor. But it is important to achieve adequate symptom control of chronic urticaria in this era. So EAG recommend that patients with biologic therapy. So in this case, our chronic urticaria, if the patient have mild or moderate COVID-19 infection cause, they can use they can continue biologic therapy, but under risk-benefit assessment and patient's consent. However, in severe case, perhaps we have to extend the interval or interrupt the therapy. That was chronic urticaria in the pandemic era. However, Marcus, you can add your comment. Recently, Professor Kokaterk and Marcus has published the global impact of COVID-19 pandemic on the management and cause of chronic urticaria, which is the COVID CU project, right, Marcus? That is a cross-sectional international multi-center study using 17-item questionnaire distributed to the member of UCARE network. The results show that COVID-19 pandemic severely impact CU patient care. So the rate of face-to-face consultation decreased, but the rate of remote consultation increased for more than 600% or something like that. Mm-hmm. And CU patient who got COVID-19 infection, 90% show my cause of COVID-19 infection. Only minority of the patient has severe cause. And CU does not affect the cause of COVID-19, but COVID-19 result in CU exacerbation in some patients. So that's my first suggestion. Marcus, do you want to add something?
No, Kanakula, those are exactly my thoughts. I would have said the same thing. Maybe stressing the last point. No, if you have chronic urticaria, you do not want COVID-19. I mean, no one wants COVID-19, but if you have urticaria and you get it, 3 in 10 patients get really bad urticaria, and this can go on for a while. No, we're seeing patients after COVID infection for up to 3 months, of really bad and hard to control urticaria. And we also know that severe COVID is even more likely to make urticaria worse, in 7 out of 10 patients. All of this coming out of the study that you mentioned, the UCARE study. And I think this also should make us think about vaccine. Today, every day, I get calls and emails from patients. Should I get vaccinated? I have urticaria. I'm on omalizumab. Is that a special? No. Look, it's very simple. Chronic urticaria is not a risk factor for allergic reactions to vaccines, including SARS-CoV-2 vaccines. So let's be very clear on this when we talk to our patients. It's also not a risk factor for the vaccine being less effective. In other news, if you, dear patient, allow yourself to get COVID-19, you are at risk of having really bad urticaria. So if you weigh these two things, very few and very mild cases of urticaria exacerbation from vaccine, and very common, very strong and long and hard to control exacerbation from the disease itself, from COVID-19, I think there's no question. We must recommend to our chronic urticaria patients to get the vaccine and to be well controlled during these times of infectious risk.
So, Professor Maurer, are you there?
Yeah, I'm here.
Okay, there's a question for you from the audience.
Okay.
They're asking if you've noticed that a lot of patients have been consulting you about the fear of allergic reactions, like urticaria after the COVID vaccine. So what would you tell them?
Exactly that, Marisha. I would tell them, your urticaria does not put you at risk of having an allergic reaction to the vaccine. And on the flip side, your urticaria puts you at risk of having really bad urticaria when you get the infection. So get vaccinated. It can be that urticaria gets a little bit worse from the vaccine, or that you get acute urticaria from the vaccine. But this is nothing compared to in number and in the manifestation of what happens when you get the infection. So always better to get the vaccine than to risk the infection.
Yes, so we all agree about vaccinations, that they are more important than fearing the urticaria itself. Okay,
Correct.
because we can now go into therapeutics. So we're now going to our next topic, which is going to discuss on treatment options and considerations for urticaria. So Professor Maurer has mentioned that there is going to be, I think, a newly published APAACI guideline. And I think, Professor, you're going to be sharing with us how to manage patients with urticaria. So let's start with your first slide.
In a nutshell, this is the guideline. No, this is the guidance. How should we treat? We should treat the disease until it is gone. Now, this is not new. This was in the previous version of the guideline, and if it is up to me, it will always be the most important sentence of the Urticaria guideline. Why? Because it shows us two things. No? It shows us that we should treat until the disease goes away, which it does, which is very important to communicate to our patients. No? There is spontaneous remission. We are working towards that happening. And it shows that we should treat the disease until it is gone, in the sense that we don't want any wheals. We don't want any angioedema, any itch. We want the disease, the signs and symptoms of the disease to be gone in our patients until the disease goes away. Marisha, I think we have another slide here that shows a little bit how the new guideline recommends to do that. So we now have 3 treatment steps that should be followed, including the optimization of treatment within the 3 steps. Now, the first one remains a non-sedating antihistamine, second-generation antihistamine, that we try for a bit, but if we see that it doesn't work, after 2-3 weeks, let's go up in the dose. And let's use 4 tablets of our favorite non-sedating second-generation antihistamines. I usually do 2 in the mornings, 2 at night. And if this doesn't work, and by work, I mean treat the disease until it is gone. If this doesn't produce complete response, including protection from sporadic triggers, well, then let's step it up. This guideline is all about step up, optimize, and then step down, which we can talk about. But step up, treat the disease until it is gone. And then once you have achieved that, maybe try to do it with as little as possible. But first, establish control, complete control. And step 2 here of the guideline is to add omalizumab at standard dose, which we can go up on or shorten the interval when the standard dose with 300 mg every 4 weeks does not work. I think there's one more, Marisha, if I'm not mistaken. Let's talk. Let's talk a little bit.
Yes.
Yeah.
But no, Professor Maurer, there is a question from the audience again about your experience, because you mentioned here omalizumab. But what is your experience on dupilumab for chronic spontaneous urticaria? How do you know which monoclonal antibody to choose for urticaria? Is it dupilumab versus omalizumab?
Great question. Thank you very much. Now, only omalizumab is licensed for chronic urticaria. We do think that this will change. So for now, the preference is with the in-label biologic. Dupilumab was just reported to be very effective in a clinical trial, probably similar to what we see with omalizumab. So it will be interesting to see moving forward, are there patients who are more responsive to omalizumab versus are there patients who are more responsive to dupilumab? And then to, based on markers, identify patients who are best treated with one or the other. We're not there yet. We're still waiting for the full results of this trial to be published. There's a second trial that is also completed now that will give us even more information. And we need dupilumab to become a chronic urticaria treatment and drug so that we can bring it to our real life routine clinical practice.
Okay. Professor Kultanan, what is your experience of how long you have to treat urticaria, especially chronic spontaneous urticaria? This is a very common question. How long should we treat? Professor Maurus mentioned treat it till it's gone, but how long is long? How long is before it goes away? What do you think?
Actually, I would like to share our data in Thailand. So 1 year passed after you diagnose the patient. After the patient begin to have chronic urticaria, 1 year passed, 30% of the patient, the disease will be in remission. But for 5-year remission, 84%. So it means that many patients still have the disease beyond 5 years. But finally, everything is gone.
Yes, but when we choose our treatment, theoretically, we have to choose something that we can take for long-term safely.
Yes.
And that it would not have any complications with other medications. So I guess we have to be careful with what we choose. But Professor Maurer, there's also another question. In this guideline, you don't seem to mention about steroids. Are there any use for steroids in chronic urticaria patients?
No, I'm going to be very apodictic and say no. Let's start with the topical steroids first. No, don't use them. They don't work. They're not good. All they do is produce side effects. How about oral steroids? We do say in the guideline that it is possible to do crisis intervention with a short course of oral steroids. But this is mainly because not all of the treatment options that you see on the slides are available in all countries of the world. I have not used cortisone in my last 5 years of practice in thousands of chronic spontaneous urticaria patients. We don't need it. We have better treatment options. Even a couple of days of an oral steroid can produce side effects, and they do. So it is not a good idea to use steroids in routine clinical practice for the management of chronic spontaneous urticaria. In fact, all the patients who come with this treatment to me from GPs or because they found some cortisone somewhere are discontinued. We stop the cortisone treatment and bring them on something that's safe and controls the disease.
Okay, so Professor Kultanan, another question about how long should the disease be controlled before you consider stepping down treatment?
So this is not you don't have the exact rule to reduce to exact duration. Exact duration. For example, for omalizumab treatment, we would like to continue for at least up to 6 months, and then we extend the duration. But for antihistamine, in my experience, I will wait about 1 to 2 months, and then when everything, for example, UCT for more than 12, Marcus will tell you later, I will step down.
Okay, so Professor Maurer, what do you think?
Look, I think the longer let's talk about why do we do step down? We do step down to see if the disease is still there and if the absence of signs and symptoms was due to the good treatment or because the disease has gone. That's the only reason you step down, because we want to have our patients on complete control until the disease goes away, but not longer. So I do the same thing as Kanakul. I have a long-term treatment plan with my omalizumab patients. Once they reach complete response, and I base that on the UCT, and here in Berlin, you have to have UCT of 16 to be considered a complete responder. Once that happens, I treat them for a year. No, some patients don't want to treat that long, and we take a break after 6 months. But most patients do want to treat that long because they remember what it was like when they were not on omalizumab. With the antihistamines, I also like to keep patients on an antihistamine that brings complete control for a longer time. let's say on average 3 months, sometimes 6 months, but also sometimes like canocculi, 1 or 2 months. This depends on how long have they had the disease. No, in someone who's had the disease for 10 years, I don't need to stop every month or every 2 months to see do they still have it. Bigger stopping intervals are good for patients with long disease. But if someone has had disease for 6 months, there is still a high chance that it will go away soon. So I can do every 8 weeks, every 10 weeks. Let's see if you still need it. And if you do, please take your antihistamine again so that you don't have any signs and symptoms.
Okay, we have a very important question here from our audience. We need to control CSU very quickly. And how can we do that in a resource-poor country where omalizumab and cyclosporin are easily accessible? Professor Kultanan, what would you contribute here?
This is a difficult question. However, actually we suggest to updose second generation H1 antihistamine up to fourfold in CU patient unresponsive to second generation H1 antihistamine onefold. However, in case that patients cannot afford the price of newer second generation H1 antihistamine, or if they are not available, sometimes we combine the different types of H1 antihistamine. It is the another choice. However, in patients with incomplete control with second generation H1 antihistamine up to fourfold, we will not increase to more than fourfold, even though the patient is not completely responsive. So we consider omalizumab. But if the patient cannot afford omalizumab, we consider cyclosporin.
Okay, so it's doable, just not as effective maybe or as safe as omalizumab, but we can actually still control even if we are in a resource-poor country. Okay, so I'd like to now go to this next discussion point. We know that the second generation antihistamines are usually the ones mentioned as first-line treatment for urticaria. So antihistamine, because they are the mast cell mediators like histamine are the main cause of urticaria symptoms. So Professor Kultanan, what would be your gauge to say that it is an ideal antihistamine, and why would you choose a second over first generation antihistamine?
So the question is first or second generation antihistamine, right?
Yes.
First generation antihistamine has pronounced anticholinergic effect, as you know that it has sedative action on CNS, and many interact with alcohol, drugs, or affecting CNS, such as analgesic, hypnotic, or something like that. And first generation H1 antihistamine can penetrate the blood-brain barrier to bind with H1 receptor in the CNS and interfere with the neurotransmitter effect of histamine. And they also interfere with rapid eye movement or REM sleep and impact on learning and performance. So we do not recommend using sedating first generation H1 antihistamine as the first line agent for the management of chronic urticaria. However, when we consider modern second generation H1 antihistamine, they are minimally or non-sedative, sedating and free of anticholinergic side effect. So they should be considered as the first line symptomatic treatment for urticaria because of their good safety profile and suitable for long-term management. So I would like to emphasize that we have to treat the patient for a long time. And there are studies showing the benefit of second generation H1 antihistamine up to fourfold higher than recommended dose, that many patients with urticaria not responding to standard dose will benefit from updosing second generation H1 antihistamine. So in summary, modern second generation H1 antihistamine at licensed dose should be the first line of the treatment, and updosing when standard dose cannot control the symptoms.
Professor Maurer,
No, you
when are
you saw me nodding. You saw me nodding when Kanakwalai was saying that. So I really 100% agree with what you say, Kanakwalai. This is important. I really do not understand why these old antihistamines are still used. No, why do we make new and better drugs? Because they're new and better. And now we have antihistamines today that are safe long-term, that are clearly better investigated for potential side effects, including cardiotoxicity, which we know in the old sedating antihistamines can be a problem. We can updose these non-sedating antihistamines and they're still non-sedating. We cannot updose the old sedating antihistamines, and they are sedating antihistamines. It's in the name. Why would I want to sedate a chronic spontaneous urticaria patient who wants to work, who wants to be a dad or a mom, who wants to enjoy life? This doesn't make sense to me at all. So please, we have really good antihistamines after 70 years of antihistamine research, and now really optimizing on the benefits of antihistamine. Let's use the modern ones. The more modern, the better. And I really want to stress what Kanakwala said. We need to treat these patients for months and years and sometimes longer. Let's do that with the most effective and the safest options we have, and that's the modern, non-sedating, second-generation antihistamines.
So, Professor Maurer, we have many second-generation antihistamines. So you'd say that the modern ones are quite different from the older second-generation antihistamines. In what way?
Look, let me take an example, and let's take cetirizine. Okay, cetirizine was the first non-sedating antihistamine that is considered a second-generation antihistamine. Let's take bilastine, just as an example of one of the most modern ones. Cetirizine makes 5 to 10 patients tired at standard dose. We know that. How many patients get tired from bilastine? 0. So that's already a difference, no? But then if you do what the guideline says and what you must do in many, if not most patients with chronic urticaria, and that is to use more than one tablet. Can you use more than one tablet of cetirizine? Well, you can, but you end up with sedation rates of 40, 50%. So half of your patients will be just as tired as they would be with an old sedating antihistamine, whereas you can go up with bilastine to 4 times the standard dose. No one gets tired. So it really makes a difference when we look at second-generation antihistamines, whether we're talking about first, early second-generation antihistamines or those that were developed after that and are considered more modern, safer, and more effective.
Okay. There's a question from the audience regarding antihistamines. Professor Kultanan, would it be worth switching between antihistamines when one type does not work?
I will updose until up to 4-fold if possible. And then if it is not work, maybe I switch before, especially in the patient who cannot pay for the higher price of omalizumab or cyclosporine. So I switch the type of antihistamine first. But for the patient who can afford, so I follow the guideline.
Okay, so thank you for that. And now I think we can go.
I would like to add a little bit.
Yes. Go ahead.
For antihistamine, I think we have to consider some specific type of antihistamine in some special population, such as patients who require high level of concentration in their workplace or daily activity, or patients with multiple drug intake. So we don't want the antihistamine with interfere the absorption of drug or have drug interaction or something like that. Patient with renal or hepatic impairment or both, or patient who have or we have to consider the effect of drug on cardiac depolarization. So that's what I would like to add a little bit.
Okay, so we still have to fulfill the criteria of the ideal antihistamine. And so now we will go to the last discussion point. And I'd just like to ask our experts that we know what the guidelines are, we have it, but what would really be, or what would it mean to us, and how could we apply it in our daily practice? What are some practical considerations that you could share with our audience? Let's start with Professor Maurer.
Yeah, look, I think this little scheme here that's in the new version of the guideline is very helpful. No, we call it step up, optimize, step down, because we want to adapt what we do to the situation our patient is in. And I cannot stress enough how important it is to monitor patients for where they stand. And my favorite tool is the Urticaria control test, very simple, available in most countries and most languages on this planet. I sometimes also or only use the angioedema control test, which is now for the first time recommended by the guideline, but I never treat patients without one of these two tests. Why? Because this test in a minute gives me the need to treat, the need to optimize, or the need to be relaxed and happy with my accomplishments and just keep patients on where they are. If I see that someone has a UCT of 12, that makes it the first time that this patient can be considered well controlled. If it's less than 12, I know that I have to do something. I know that I have to change something. Why? Because the disease is not controlled. And what's my goal? To bring patients to control, complete control. So in the red zone, I know action required. In the orange zone, I want to optimize. I want to figure out how to make it work to bring to 16. And when I'm at 16, patient is happy, I'm happy, I move and I keep this. And eventually, we talked about this, Kanapolai and I, eventually we will ask ourselves, is it still needed? Is it still required? And that is when we can start to step down to bring on board this as much as needed, but also as little as possible. But first, let's bring patients to control. This is what the guideline says loud and clear. And this is also how I work with my patients here in Berlin.
Okay, so what about you, Professor Kultanan? Knowing the new guidelines,
yes, I absolutely agree with
Asia, can we adapt them?
No, I follow the guideline. Actually, I would like to add a little bit about practical challenges in Asia. We know that this is the ideal, but in Asia, some doctors still add H2 blocker or to H1 antihistamine or prescribe first generation antihistamine before bedtime, hoping to help the sleep problem in the patient in order to get UCT of 16 or something like that. What, Marcus, what do you think?
Look, I think it really depends on the country you're in. In my country, the biggest problem is that non-expert physicians do not step up. They do not increase the dose of the antihistamines, and they do not switch to omalizumab. And in my country, omalizumab is readily available. No one has to pay out of pocket for omalizumab. And so I don't understand how it takes so long before patients get higher dose of an antihistamine or get omalizumab. Now, this is different in other countries. I know that. And when you do not have omalizumab, or you can't access it, or the patients can't afford it, well, then you start to try things. And then it is fine to deviate from the guideline, because the guideline always works with the idea of do this when you can. But when you cannot because you don't have the drug, well, then you have to be creative. And the guideline does provide some fallback options, and they include H2, they include leukotriene antagonists. But please don't do that when you have access to what the guideline actually recommends. So this is the spirit of the guideline, and I think it makes sense to apply that depending on your local, regional, national setting.
Okay, so we'd like to discuss more. There's so much to discuss, but we have now to wrap up, and we have the last 2 minutes, like in basketball. So may I ask each of our speakers to give a 1-minute wrap up, please? Professor Kultanan?
So 1 minute. We recommend the International EAGI guideline for the diagnosis and treatment of urticaria. However, the therapeutic effect and adverse reaction of the drug may vary depending on the ethnic variation, I think so, comorbidities and concomitant medication. And the healthcare system of each country may be different. So that's mine.
Professor Maurer?
Agree with everything. Dear listeners and viewers, thank you so much for joining us. Thank you also for embracing urticaria. You have no idea how important it is for urticaria patients to talk to physicians who like to treat urticaria, who tell their patients, I know what this is. You're at the right place. I can help you, because it's a devastating disease and we must bring control to our patients, and we can. So let's make use of the guideline, and let's make use of the very, very good treatment options we already have. Treat the disease until it is gone. Thank you.
Wow. So I guess everyone agrees that we really had a very fruitful interactive discussion, even with our audience. And thank you so much, Professors Kultanan and Maurer, for sharing your insights on urticaria. And thank you very much, everyone, for listening and participating. Good afternoon.
Thank you.